Sylvia is with the background of biochemistry, and Dr. Patel, she's a nerd like me, an INTP, so they like to know everything, the mechanism of action, how things works. So I think this is more of a session, which is CME. It's going to be talking about more about the mechanism of action, how things works.
Right.
Indeed.
I enjoy the way you describe how things really work, right down to the basic physiology and biochemistry. That's me. I don't know about other people. I enjoy learning to understand it.
Yes, without understanding the mechanism, you're not a physician.
Right. I agree with you. I mean, I can see there's more than one INTP here. I mean, I can see Dr. Sylvia is one of them, and Dr. Patel, and so we have the same mindset. I did share the 16 personality to Marie. I asked her to test herself and find out. But I learned this from Dr. Joseph. I don't know if Dr. Joseph is there. Are you Dr. Joseph there? He brought this 16 personality thing and made everybody here crazy about it.
It's fun. I would love to do a teaching session because it goes a lot deeper than people think, and it's very accurate. You cannot deny it once you see it, but you have to understand it's more than just somebody is an introverted, intuitive, thinking perceiver. That's just code. That's where so you have to know there's a whole algorithm of functions, and people have functions that are very dominant, and that's really explaining how they are. And me, it's pattern recognition, logic after the patterns. That's the only difference between ENTP and INTP. INTP is logic first, and then they see the patterns. Me, I get all the patterns, and then I tease out the logic, and that's what makes me look chaotic. But you can just instantly, and you can predict the kind of diseases that patients will have. That's the beauty of it, is there's a pattern in which personality types are more susceptible to certain diseases. Even autoimmune diseases are much more common in the so-called intuitive personality types versus the sensor types, which that would make more sense after I actually taught it.
No, I agree with you, and I'm being obsessed about the testing of the personality. It just helps us to communicate with each other better, and then understand Dr. Patel why she's asking those questions, and Dr. Sylvian why, among all others, he's the one who's asking those deep questions. It indicate that there is something about them, that they are very obsessed about the chemistry and the mechanism of functions, and they cannot take things without being analyzed, and they cannot sleep at night. They will start thinking until they figure it out. And some people, they don't even care about they will sleep and it's fine for them. But for those people, if they cannot answer the questions, it's going to be a nightmare for them. So it's very important that I help those people to get their answer so they can sleep. Otherwise they will stay up all night, and we don't want that. So endothelial dysfunction in chronic disease, basically any chronic disease, whether it's inflammatory, degenerative, autoimmune, eventually they all end up into oxidative stress. And oxidation means damaging endothelial cells. When the endothelial cells are being damaged, then they don't produce enough nitric oxide. And if they don't produce enough nitric oxide, you don't have this kind of vasodilation and flexibility of the blood vessels. And oxidative stress and inflammation can also lead to fibrosis and stiffness of the blood vessels. So, endothelial dysfunction, it's a very good test to test the general oxidative status of the patient. So it is more general, sensitive test, but it's not specific. We don't know what caused the oxidative stress with this testing. We may predict, we say, oh, if you have severe endothelial dysfunction, then it may be associated with increase of the clotting factor activated. Yes, that's kind of prediction based on data, but we're not measuring the clotting here. or when you have severe endothelial dysfunction, that's mean there's lots of oxidative stress. We may think that thyroid is also being compromised because of the oxidative stress, but we're not really measuring the T3, T4. We're just saying it's a reflection of an increase or high oxidative stress, which may compromise the thyroid. And so when we wanna know where the oxidative status of the patient, then we use endothelial function test, and it will give you also the gray area, the subclinical oxidative stress. That all the testing that we have, which is those vital signs, blood pressure, oximeter, all that stuff, they may see them abnormal in the red side, in the clinical side, but in subclinical, really we don't have much of testing to know or detect those subclinical oxidative stress and inflammation in general. So having some test, like endothelial function test, that reflects the oxidative status of the patient, it's a good test to use it to screen patients, and knowing, hey, there is oxidative stress. Yes, it's not manifested. Patient looks normal, vital sign is normal, all the lab is normal, but the patient has oxidative stress because the endothelial function is abnormal. And so they are in the gray area. They're in the subclinical. Maybe we'll see all the lab is normal, but there is some sort of leakage of free radicals or source of free radicals. It could be because patient is diabetic. It could be because patient has hypertension. It could be because the patient has leaky gut, toxins from the gut is getting into the body, those free radical generators. It could be because patient has Lyme disease or mycotoxins, or patient has rheumatoid arthritis. Inflammation of the rheumatoid arthritis is damaging the endothelium. And that's why the big pharma can use the endothelial function test to monitor the efficacy of the anti-rheumatoid drugs. If the anti-rheumatoid drugs is decreasing the inflammation, you will see that the autonomic nervous system and the endothelial function is normalized. And so it helps us to know whether those drugs are working or not. And what's important for me is the function of the body, not the level of those chemicals in the body. And so that's the reason I like endothelial function test, because it gives you the function of the body. Is it optimal or not? And let's say if the oxidized LDL is high and endothelial function is normal, I don't care about oxidized LDL. But if it oxidized LDL is high and the endothelial function is abnormal, I do care, right? Because I care about the function more than the level of the chemistry of the body. And functioning endothelial cells means that the blood vessels is relaxed, and it means that there is the oxidative stress is being minimized or optimized. And also oxidative stress, as I said, it could be from chronic inflammation, could be allergy, it could be degenerative disease, it could be toxin, it could be drug, it could be chronic stress, whatever stress it is, chronically. If it's acute, the patient will recover once the stress is out. We're talking about the chronicity and damage of the endothelial cells. And so patients with rheumatoid arthritis, they will have problems because those inflammation that's coming from the autoimmune of the rheumatoid arthritis can cause damage in the endothelium, and that put the patients at risk of cardiovascular diseases. And so there is a connection between inflammation and endothelial dysfunction, or oxidative stress and endothelial dysfunction. And so if you manage atherosclerosis, you will definitely help to minimize the risk of the cardiovascular diseases, because you are helping in decreasing the insult over the endothelial cells. Because if the endothelial cells being insulted, then you put the patients at high risk of atherosclerosis and deposition of the plaques and all the things that we talked about, and the fibrosis and all that. And we're talking about any kind of inflammatory disease, whether it is psoriasis, lupus, rheumatoid arthritis, inflammatory bowel, any inflammation. Can you see the slides? Is it clear, the slides? Everybody? Hello?
It's clear. It's clear. Slides are clear.
Yeah.
I mean, it's just one slide.
There you go.
Endothelial dysfunction is a critical step in initiation and maintenance of the atherosclerosis. And if we optimize the endothelial function test, if we see patients in the gray area and we move them into green area by using all the treatment we talked about, nitric oxide supplement, cyclodextrin, many times I put cyclodextrin, because cyclodextrin is the only drug that can clear and clean the blood vessels from the cholesterol, and also it has anti-inflammatory effect. It's like high density lipoprotein. And so if we can create a supplement where we load nitric oxide and thiols inside the cyclodextrin, that would be a great thing. Plus, normalizing the 6 hormone is very important as well, because we know the 6 hormones, they increase the expression of the NOS, of the nitric oxide synthase, and increase the nitric oxide. So if you have low 6 hormone, you have low enzyme that makes the nitric oxide, you end up with atherosclerosis or endothelial dysfunction. And so giving progesterone, I like to give progesterone intranasal, because progesterone is a unisex. It's not a male or female 6 hormone. It's a unisex, and it feeds both the testosterone production and estrogen production for female. And it doesn't have much of side effects, versus if you give testosterone, it may cause, or estrogen, it may cause ovarian or testicular atrophy. So I like to give progesterone intranasal along with cyclodextrin, and Mike Emmanuel is making good ones that I do recommend. Patient with chronic inflammatory disease often exhibit endothelial dysfunction early in disease, of course, and we can easily detect that through the system, and we can start shifting it or start managing the patient until we push them from the gray area to the, which is the subclinical area, to the green area. Dysfunction is characterized by impaired vascular relaxation, right? A little bit rigid, and increase the leukocyte adhesions, increase the endothelial permeability, and the prothrombotic scale state. So again, if the patient has severe endothelial dysfunction, yeah, we expect that the clotting factor is being activated. So the system does not measure the clotting factor, but they are predicting if it's severe, then you may have a problem with the clotting. So that's very important, that the people will not be misinformed that the system is measuring any clotting factors, or it has a spectrophotometer, and it's just more of, if the endothelial function is severe based on the data they collected. They collect patients with endothelial dysfunction of this level of severe, they find out that they have problem with their clotting, and based on that they are predicting. But definitely you need to test the C-reactive protein and the clotting factors to confirm that. So what is the mechanism of endothelial dysfunction? Several factors contribute to endothelial dysfunctions. Again, chronic diseases, whether it's inflammatory, autoimmune, it could be metabolic, increase the diabetic, you have too much of glucose or too much of insulin, and glucose are free radical generators. The sugar, it oxidizes, they become glycans, and they can cause damage in the endothelium. And so it could be because of rheumatoid arthritis, and you have inflammatory cytokines, and that leads to oxidative stress and damage of the endothelium. And some of those cytokines that we know, interleukin-6, tumor necrotic factor, all of those can lead to inflammation and damage of the endothelium. So if your patient has rheumatoid arthritis, they have high risk of having endothelial dysfunction, atherosclerosis. And managing rheumatoid arthritis, it leads to management of the atherosclerosis. It's very important that the flare-ups, it's being taken care of. And if we see the flare-ups of the rheumatoid arthritis, you will see the sympathetic overactivities, and you will see that there is some sort of autonomic neuropathy very clear as well, and endothelial dysfunction. Any source, any cause, anything that leads to reactive oxygen species generation, whether it could be leaky gut, where the free radicals generators from the toxins of the bacteria has been leaked into the gut, into the bloodstream. It could be because the drug patient is taking is not metabolized well. It could be because of Lyme disease. It could be because of deficiency of the 6 hormones, or Patients had some metabolic errors, deficiency of vitamin D, B12, folic acid, name it. So we need to figure out what caused this oxidative stress. And yes, patients, if they are taking too much of sugar, and the sugar turns into glycans, they get oxidized, and then the glycans can oxidize the LDL, and they become oxidized LDL. So yeah, high LDL will oxidize endothelial cells. Again, the LDL itself, if it's not being oxidized, it's not that much of a problem. But when it's oxidized, it's a problem. So if I have high LDL and I don't eat a lot of sugar, that's fine. But if you eat sugar and you have high LDL, the sugar will turn into or get oxidized to become glycans. So because sugar is free radical generators, and they will oxidize the LDL, and that's the problem. Then the oxidized LDL will damage the endothelium and cause atherosclerosis. Anybody has any autoimmune disease, lupus, anything that you have autoantibodies, those immune complex can cause damage to the endothelium and can accelerate and cause endothelial dysfunction. And so anything that leads to inflammation, oxidative stress, it can hypertension because of the mechanical stress leads to damage of the endothelium. Insulin resistance, right? And too much of insulin and too much of glucose, those are free radical generator. Insulin is free radical generator because it induces oxidative stress in the tissue. And the sugar itself, it is a free radical generator. And all of this can lead to diabetic metabolic syndrome. Estrogens from the estrogens or testosterone that's converted to estrogens or because of the fat. So if patient is obese and fat, they are converting their testosterone into estrogens and estradiol into estrogens. The estrogens is inflammatory and it can lead to atherosclerosis. So obesity is not a good thing because it can lead to estrogens and inflammation and damaging of the blood vessels. So it's very important to optimize the health is to reduce the weight. And the good thing is that the test that we talked about, it does help to measure the fat distribution by electrical impedance. The more fat you are, the less you don't conduct electricity as much. But if you're skinny and muscular and you have a lot of bone, then you pass electricity. And with the logarithm, they can know the ratio of the fat, muscle, and bone. That's the beauty of the system. Okay. So this is the mechanism. Then we have the epidemiology and the clinical findings. Chronic autoimmune inflammatory disease are linked to accelerate atherosclerosis, rheumatoid arthritis, lupus, right? Systemic psoriasis. All of this can lead to acceleration of atherosclerosis. And so we need to really manage those patients. We make sure that their inflammation is being under control. We make sure that Th17 is being inhibited. If they have excessive Th1 is being inhibited. Even allergies can cause damage because they are too much of Th2. And so any inflammation needs to be taken care of. We need to balance it. That's the reason, when we are managing chronic diseases, we use those 4 pillars, right? We need to manage the redox. We need to check any metabolic deficiency or metabolic errors like too much of sugar or low 6 hormones. All of this needs to be balanced. And then we have the immune status needs to be balanced. And that's why we do lymphocytes mapping, cytokine profile, and check the immune system and how we can balance it. Because if you don't balance those things, then you will end up with damaging of the endothelium and putting the patient at risk of atherosclerosis. And then using endothelial function, we can help to know whether you balance it or not. If the endothelial function is not being corrected or it's not being fixed, that's mean there's a problem with your balancing. Either your immune is not being balanced, your metabolic is not being balanced, your redox is not being balanced, or the patient's regenerative status, it's being compromised. That's why we may need to give the patient clotho and exosomes or oxytocin to restore the regenerative status of the patient. And of course, atherosclerosis can lead to cardiovascular and can lead to increase the mortality and morbidity. And so the link of chronic inflammation, degenerative disease, Parkinson's disease can lead to endothelial dysfunction. It's a form of oxidative stress and can lead to autonomic neuropathy. We know that for sure. And because it's an oxidative stress. And we need to normalize it as much as we can. Give them the thiols, what we call it, the NAC, give them, of course, normalizing the L-DOPA as much as you can, but managing the oxidative stress and degeneration of the dopaminergic neurons is very critical. It's not just enough to give L-DOPA, because L-DOPA can turn into quinins, and quinins can cause more damage and more degeneration. So it's very important to optimize the health and look at the 4 pillars that we talked about. Look at balancing the metabolic, immune, regenerative, and redox status of the patients, and screen them diagnostically. See if there's any balance of all of those 4 things. So any inflammatory disease, any degenerative disease, any autoimmune, any allergies, any chronic disease can lead eventually to oxidative stress, damage in the endothelium, and leads to increase the risk of atherosclerosis and stroke. So all of this needs to be optimized. And how I know it's being optimized, how I know that the Parkinson is under control, the rheumatoid arthritis is under control, is by testing the endothelial function test. If it's normal, then there is no much of inflammatory cytokines there. If it's abnormal, then there is problem. Your rheumatoid arthritis is not being controlled. Let's say, well, if I check the immune balance, everything is fine with rheumatoid arthritis. Well, maybe the patient the endothelial damage is not just because of rheumatoid arthritis. Maybe the patient has Lyme disease. Oh, you need to fix that, right? If the patient say, okay, I fixed the immune is balanced, it's good, and still the patient has endothelial dysfunction. Well, maybe because he has leaky gut. So it's very important. That's the difference between us as integrative doctor and the mainstream medicine. Mainstream medicine, okay, I fixed, I give them anti-rheumatoid arthritis. I don't care about other things. No, as integrative doctor, no. Endothelial function, is it fixed or not? Okay, yes, you fixed the rheumatoid arthritis, but endothelial function is still abnormal. Well, it's not because of the rheumatoid arthritis. It could be other things that the patient is being overlooked to. It could be because the Lyme disease is not being checked. Well, Dr. Patel will check it. I don't think she will leave that. Or because the patient has leaky gut, or because the patient has deficiency of the 6 hormones itself. And so when you optimize all of this, then you will see an endothelial function is normalized into green. And if it's not in green, the patient is still sick, and you are responsible for these patients. And that's the difference between the mainstream medicine doctor and us as integrative doctor. We want to push the patient to the green zone. We don't want to keep them in the gray zone. Mainstream medicine, as long as they're not in the red zone, they're fine. If they're in the gray zone, I don't care. They don't have any symptoms. They're okay. Go home. No, we don't want them in the gray zone as integrative doctors. We want to prevent them from going to the red zone. We want to start moving them into the green zone. And that's the difference between the mainstream medicine doctor and integrative doctors. And if we do that, and we move all the patients and all the people, not just the patients, because normal people, they are normal. Clinically, they're normal, but subclinically, they're abnormal, right? I have a cousin of mine, he's completely morbid obese. But when we check all the lab, everything is normal. Sugar is normal. Cholesterol is normal. Everything. Blood pressure is normal. But he's morbid obese. Right? I don't think they check the 6 hormones. I don't think they check the endothelial function. No, study is not being checked. Of course, it's going to be abnormal. And that's the reason we have better tools to move the patient from the subclinical into healthy person, from subclinical disease or subclinical oxidative stress, subclinical degeneration, inflammation, into into optimized healthy person, the green zone, which endothelial function is normal and the autonomic nervous system is normal. And so we know the vital signs. When you have high blood pressure, you check that temperature. All those are parameters that we use, but it's good for the red zone, for the clinical conditions. But when it comes into subclinical, they don't really detect that. So you really need to find something that's more sensitive. Endothelial function and endothelial cells are very sensitive to the oxidative stress and inflammation in general. And that's why we take advantage over that. And also the autonomic nervous system, very sensitive and in the form of heart variability. With all the logarithm and the advance of the logarithm and the AI, then we have better results reading from that. Assessment of the endothelial function test. How you assess it, whether you can use flow-mediated vasodilation, the things that we are using, which is a little probe in the finger, and then we squeeze the brachial artery with the cuff of the blood pressure, and then we relax them, and then we see the refilling of the capillaries of the blood vessels. And also there is also measurement of the pulse volume and change, and all this data. They will tell you about the stiffness of the blood vessels in general. All right. That's one way of doing it, which is called the reactive the one that we use is reactive hyperemia, peripheral arterial tonometry, the PAT. That's what they use for the system. But you can use ultrasound as well, Doppler ultrasound, and see the blood flow after you squeeze the brachial artery and then you release, and then the ultrasound will tell you about the stiffness of the blood vessels. So there is a way that the ultrasound, there's a new ultrasound that they can detect the stiffness of the blood vessels as well. And the change that's happening. And then we can go ahead and do the testing, the biomarkers like oxidized LDL, adhesive molecules, all those just gives you another indication of endothelial dysfunction, right? You can use lab testing and find out the biomarkers such as nitroxide metabolites, endothelial 1, adhesive molecules. All those can be a good lab testing that reflect the function of the endothelial cells. Or we can use endothelial progenitor cells. I think Dr. Shi will be a good, if he can start testing this. And the number and the function of this endothelial progenitor cells, if it's low, that's mean you have an abnormal endothelial dysfunction. So this is something Dr. Shi can do it. Glycocalyx also, Dr. Shi can do it. It can measure the glycocalyx, which is the protective layer. They use it. I think there's a test for that. They check it in the eyes, some sort of, and they find out the integrity of this glycocalyx using some sort of dark field imaging, right? And I saw that testing in the A4M. And damaging to glycocalyx means that you have problem with your endothelial. So there's many ways, but the more fasting way is the one that we use, which is the probe that we put in the finger, the infrared camera that detect the waves of the pulse, and plus the heat that's coming up, and the speed of the heat based on the capillary refill. And there's a lot of logarithms to calculate to tell you exactly the stiffness of the blood vessels in general. So again, we need all the testing. We need to do all this lab testing to find out what's the source of those free radicals that disturb, that cause endothelial dysfunction, that cause autonomic nervous system, that cause pseudomotor to be abnormal, and then find the treatment. It could be Lyme. Go ahead, manage the Lyme. Could be leaky gut. Manage the leaky gut. Those are free radical generators. It could be deficiency of vitamin D. Fix that. 6-hormone. Could be the drug that narcotics patient's taking. Could be a source of oxidative stress. It could be too much of statins. Yeah, statins can interfere with mitochondria. So make sure that you give them the right supplements to protect the mitochondria from the statin. Yeah, statin is good. It is nitroxide. It increases the nitroxide production. So it's good. I like it. It may lower the cholesterol, yes, but lowering the cholesterol too much is not good, because then you want to compromise the 6 hormones, and then you don't have enough of 6 hormones, then you end up with endothelial dysfunction, oxidative stress. So that's the problem with the big pharma. They have a good in the short term, but in the long term, it's not good. So the much that you can replace the big pharma with supplements, it's better. So statin you may be used if the patient has very high cholesterol and is eating a lot of sugar. You may give it for a while and then try to replace it with something different that's more like berberine or something, and change the lifestyle and ask the patient not to eat sugar. Because statin can interfere with 6 hormones. They inhibit the cholesterol, and then you don't have enough of cholesterol to produce 6 hormone. And if you have low 6 hormone, you end up with oxidative stress and damage and endothelial dysfunction at the end of the day. And so you need to find the cause of those source of those free radicals inflammation. It could be rheumatoid arthritis, could be diabetic, hypertension. All of this needs to be normalized. Now, if it's hypertension, again, progesterone is a vasodilator. So that's the reason patients above 50. What we have patients above 50? They have problem with sleep. They have problem with their sexual performance because of low 6 hormones. They have too much of fat because of the low 6 hormone and estrogens, leading to the fat and moving things into cortisone, from 6 hormone dominance to cortisone dominancy. They have lean muscles, as bone is atrophy, and again, they have some of them. They have even blood pressure a little bit high, and endothelial dysfunction, right, when we age. And so giving progesterone intranasal along with cyclodextrin is a great solution, cover 50% of the problem, because progesterone will feed the 6 hormones and possibly normalize it. So that's good. And that will improve the endothelial function. And also it leads to production of nitric oxide and causing vasodilation. So it helps the blood pressure is high. And then the progesterone turns into GABA, or it is GABA-like chemical, it's metabolites, and it helps the patients to sleep. Okay, and you have a full coverage of sleep, which is very important, to sleep to detox the body. If you don't sleep, you don't detox the body, you have too much of free radicals. Sleep is very important to clear and detox the body, because those toxins are free radical generators and can cause endothelial dysfunction. So just giving progesterone intranasal along with cyclodextrin to all the patients above 50, I will recommend it to everybody above 50, unless they have problem with progesterone, like patient has meningioma tumor and they have progesterone receptors, and possibly this can cause recurrency. That's the one you need to check with the neurosurgeons about it. Otherwise, everybody above 50, take progesterone. It's better if you take progesterone than taking testosterone and estrogen. If the progesterone is enough to feed and give you enough testosterone and estrogen you need, then you don't need to give those end 6 hormone. You just give those upstream ones to feed the cycle. And then you don't have problem with ovary atrophy and testicular atrophy of giving those end 6 hormones. And because of the vasodilation effect and many things, there's also some studies about using progesterone for managing COVID and post-COVID as an anti-inflammatory. Progesterone is very effective anti-inflammatory. I don't like to give it orally because I don't want to burden the liver. So bypass the liver, giving it intranasal. It gets into the brain, so it gives you that calming effect, relaxing effect. And using it at night, 2 spray each nostril. I think Dr. Stephanie did report very good about it. And it does help your endothelial function. And also it prevent the switch from 6 hormone dominant to cortisone dominancy that happened during the age of 50. And so this is something you need to add it down in your protocol. Everybody needs to be on, above 50 needs to be on intranasal progesterone and cyclodextrin, along with a lot of good things about cyclodextrin that we talked about. And plus nitric oxide supplements and thiols, and then you look for all the other metabolic problems if the patient has vitamin D, whatever, that you see, and make sure you balance the immune system and the thing that we talked about, the 4 pillars of the chronic disease prevention and management. that we wrote a book about it, Introduction of Chronic Disease Prevention Management. I'm waiting for Shell to edit that book so we can publish it. It's a very short book. It's not a long one. It's just 100 page. It's not a textbook, but it's a good introduction. It has those 15 modules. And so any treatment that we do, whether it's anti-inflammatory, antioxidants, redox therapies, metabolic therapies, that helps to decrease oxidative stress and improve endothelial function test. So if you're managing the rheumatoid arthritis with anti-rheumatoid drugs, you are actually managing the endothelial function test as well, or endothelial function. And so those anti-inflammatory therapies, including tumor necrotic factor alpha inhibitors, interleukin-6 inhibitors, losartan. Losartan is very good. It's antifibrotic. I like losartan, by the way, especially low dose, like 10 or 5 milligram a day. It helps to keep the blood vessels relaxed and take care of the fibrosis side of it. So above 50, I like patients to be on losartan 10 milligram as an anti-aging and also helps in atherosclerosis. Nitric oxide supplements. If you require some exosomes, restore regenerative status, look at any metabolic problems. Patients diabetic, give them low carb diet. If the patient has vitamin D deficiency, leaky gut, toxins, all this needs to be screened. And it's based, you don't do it just random. You really take good history and physical exam to narrow down what kind of lab you do and what kind of treatment you do. Okay, it's very important to prioritize things because it's very going to be costly if you just do everything. So based on the data you collect from the patient, from the history, physical exam, and the lab, then you come up with the right protocols. So again, it's not just anti-inflammatory therapy, and regenerative therapy, redox therapy, metabolic therapies, all of this that helps to decrease oxidative stress, subclinical oxidative stress, not just the clinical ones, will definitely help to improve the endothelial function test to the green zone. It's very important to turn the endothelial function test into the green zone. And if the endothelial function test is still abnormal, you need to look and search why. You don't just say to the patient, oh, you don't have any symptoms, any signs, you're okay, go. No. Get the autonomic nervous system balanced and get the endothelial function test balanced in the green zone, and then release the patient. Then say, hey, you're good. But you give the treatment and say, patient, I'm not feeling anything. Why am I receiving the spread to treatments? Well, you're not feeling anything, but there is inflammation, oxidative stress that's running under the ground. You're not feeling it. It's not manifested, but it's good if we can stop it. So we prevent it from being manifested and turn it into green zone. And that green zone means that you are slowing the process of the aging. You cannot slow the process of the aging if you're in the gray zone, right? If you have a visceral fat and say, I want immortality, it's not going to happen. You have a visceral fat, man. You need to get rid from it. All right. It's very important. You just don't tell somebody who's obese or fat or has visceral fat like me or have gynecomastia, very clear, and you say you're normal. It will come one time of maybe in the future, maybe in 20 years or 30 years, where visceral fat, gynecomastia, if your body is not optimized, they will see you as a sick person and you need to go through all the treatments till you optimize. It will be one time mandatory, because they will find if we do that, we spend money and turning patient from the gray zone to green zone, we can save a lot of money of managing the red zone, which is the clinical cases, the manifested cases. If we spend the money here and all the employees, they will go through this testing and we optimize all the employees of the companies. Their weight is optimized. The fat is optimized based on this test. You can measure the fat, by the way. And your tier is optimized. All the employees, if they don't have the check, if they don't see it every 3 months and it's not normalized, they need to go through this treatments. They have to go integrative doctors, and the government needs to pay for it till they optimize. And you will see everybody look nice inside and outside. Think about, you go outside and everybody's with a nice, curvy, beautiful body. Right? That's the future. Okay. And so we can create the future from now. We can start it and say, hey, let's do it from now, and mandate this. And the government or the company needs to pay for this. And if you will save a lot of money, the government, the whole country will save a lot of money if you work on prevention. If you move patients from the gray zone into to the green zone, you will save 10%. I mean, you will be saving 90% of the per capita. How much we spend per capita, by the way, in the United States? Do you know how much for chronic disease? In general, we spend $12,000 per year per person. $12,000. $12,000 per year per person. That's how much it costs in the United States. We can turn that into $1,000 per year per person in the United States if we work on this, and we save 90% of the money that's being wasted because of spending the money when the patient is in the red zone. It's very expensive, by the way, to turn the patient from red zone to gray zone, and most of the time they don't even care to move them to the green zone, by the way. Once in the gray zone, they're normal. Right? Go home. For patients with chronic inflammatory disease are high risk of cardiovascular, and we explain why. And this heighten the risk and reflect an early endothelial dysfunction, even in the absence of detectable atherosclerosis. So knowing the endothelial function and normalizing it, we can prevent the whole process of atherosclerosis. And that's a good thing, right? Because stroke and cardiovascular, it's a very high incidence. And why? Because we don't take care of those patients in the gray zone, the subclinical ones. And why? Because all the testing that we have, it's for the red zone, not for the gray zones. And if we start testing people and we find them abnormal in the gray zone, then we can, which is subclinical, then we can save a lot of a patient from going to the because once they get into atherosclerosis, it's just even hard to reverse it, by the way, and go back. It's just very hard to turn those blood vessels back from the red zone to the gray zone. It's easy to turn it from gray zone to the green zone, but it's very difficult from the red zone, which is the clinical, to subclinical. And so we can definitely prevent atherosclerosis from the beginning, and because once you have a fibrosis, it's going to be very difficult to break those fibrosis back. So if we start early, we can prevent the fibrosis from happening. And so this just shows you that it's very important to normalize the endothelial function. And by giving nitric oxide supplements or the ingredients that produce a nitric oxide, like all the vitamins needed to make nitric oxide, and giving nitric oxide itself along with thiols, this will prevent the atherosclerosis. And in order to prevent endothelial dysfunction, we need to look for all the leakage of the free radicals generators, whether it's from the sugar, from the diabetic, from the stress and the shearing force of the hypertension, or from the estrogens, that's from the fat tissue, from the obesity, or from Lyme disease, or from toxins. All of this, we need to look at it, neutralize it, and improve the endothelial function. And we talked about the pseudomotor testing again and again. Pseudomotor is for the neuropathy, and neuropathy, whether in the foot or generally. It's unmyelinated fibers of the C fibers, and the sympathetic is unmyelinated fibers. And we're assuming that when the sympathetic is inflamed and they're not functioning and they are not secreting enough of norepinephrine and they're not vasodilating the sweat glands, and the sweat glands is not functioning and producing enough of sweat. And when the sweat is produced and is little, then all those salts will be reabsorbed and the sweat will be diluted with less salt, and the conductancy will be low. That's mean that the patients may have neuropathy, and autonomic neuropathy plus pain neuropathy, C fibers neuropathy, because they are unmyelinated fibers, both of them. And so it's a good test for neuropathy, but also it's a good test for generally there is an autonomic neuropathy. And autonomic neuropathy or C fibers neuropathy, neuropathy in general means that you have oxidative stress in your body, inflammation. And you need to find out the source of that inflammation. Is it because of the sugar and insulin? Patient with diabetes, or it could be because of Lyme disease, whatever. You need to find the source. It could be because of vitamin D deficiency, sex hormone deficiency. You need to find the source. It could be patient has rheumatoid arthritis, and neutralize those free radicals. Once you neutralize the free radicals, your autonomic nervous system will function back. Your heart variability will go back normal is. And if you normalize that autonomic nervous system and it's working, the heart variability is working, you don't have that tiredness and brain fog. Possibly brain fog is possible. It could be due to neuropathy, autonomic neuropathy due to inflammation, oxidative stress. Patient with psoriasis and say, I feel dizzy and brain fog. Of course you feel dizzy and brain fog. The psoriasis inflammation means endothelial dysfunction, means autonomic dysfunction, neuropathy. And when you stand up, yeah, you don't have much of blood go to the brain. You end up with brain fog. That's normal. So there's inflammation, plus the microgliosis and all that stuff directly in the brain due to the psoriasis. And so you have to reach out or approach the patient with chronic disease with 4 pillars, looking for the immune balance, looking for all the problems with immune, what caused it, redox, metabolic, and regenerative status at the end, and normalize it, and all the metabolic. And when I'm talking about metabolic, I'm talking about just the cholesterol and the sugar and the blood pressure. No. I'm talking about anything: vitamin D, magnesium, B12, deficiency of L-DOPA, deficiency of acetylcholine in patient with Alzheimer's disease. Any metabolites, any chemistry in the body needs to be normalized. And that's what the metabolic status of the patient needs to be normalized. And it's all based on history, physical exam. You can find out exactly what's going on with the patient. But I use those 4 pillars for diagnosis and then for treatments. And so, as we said, the conclusion here, there's strong evidence that mechanism responsible for accelerating atherosclerosis in patients with inflammatory diseases or degenerative disease, oxidative stress. And we need to provide the early intervention to prevent atherosclerosis from happening from the beginning, and spend the money in turning the gray zone, the subclinical, into healthy, optimized status of the endothelial and autonomic nervous system. And it could be, as I said, all the sources of the oxidative stress could be because of autoimmune, rheumatoid arthritis, degenerative disease, whatever. You need to figure out the source of those free radicals and inflammations and neutralized. I think we're good. Any questions? Any questions? Everybody's happy?
Happy.
Right? I think we removed the sharing. So again and again,
Oh, yeah.
without
One sec. Can I ask you a simple question? What is the easy way to measure endothelial function, with the blood vessels, either the brachial artery or or the fingers. What's a simple way to do it in the office? One doesn't need a $50,000 machine. You know, what's, you know, a simple, practical way to do it?
Well, the reason the $50,000 machine is just because they take a lot of data from the infrared camera that they have in the probe and the finger that detect the speed of the heat as the blood capillary refills. That's one.
Okay,
Then they take the data of the pulse itself, right?
right,
And
okay,
all those data, they have it in their logarithm, and it gives you better understanding of the endothelial function and the rigidity or flexibility of the compliance of the blood vessels. It just it gives you the more sophisticated the system, it's and giving you a report where it shows you you are the green zone, the gray zone, or on the red zone. It's a good system. The first system that they generate, I have to make those calculations and numbers and subtract and multiply and do it manually, right?
Mhm.
The first
Mhm.
system. Now they are doing everything. It's more automatic and give you the result like this and instantly, and you can and it's more faster than the one before. One before you spend more than half an hour. This one maybe 7 minutes. So the more the system is complex and the more they give you the data along with the informations that they collect from patients with all this different degree of endothelial function, what they are associated with most of the time. So it's based on epidemiological studies from many years of data collections. So that's the reason. There is a billable system for that. There's insurance pays for it, not this one. There's another system, but it doesn't have that much of parameters. Like doesn't have the fat distribution ones. This one has the fat distribution. If you buy just the fat one, just to measure the fat ratio, that is another $10,000.
Right.
Many
But,
different system for that.
I mean,
Dr.
they've had
Halasa,
the functional tests I've seen in offices. You take the blood pressure, you know, over the brachial artery, and they had some not particularly sophisticated machines would give you a pretty good projection of what's happening. And these are not, I mean, not sophisticated machines, but they gave you a pretty good idea, I think. I don't know much about it lately, but I mean,
Yeah, there's ultrasound.
Dr.
You can do
yeah,
it.
Dr.
ultrasound.
Halasa, Dr. Halasa.
Yes.
So, do you think maybe the difference between this method and the traditional method has more to do with the sensitivity and perhaps capturing what's going on even with the microcirculation, whereas maybe the traditional method is not quite as sensitive. You're able to pick up more of the function of the larger blood vessels, and so therefore you may be missing, like I said, like the gray zone. There's there could be things missed with the traditional test where this is getting down to the microscopic level in a sense.
I think this one has more data and more logarithm collected from not just the heat that's coming up from the blood as they refill. It's like a camera there and their finger, but also the pulse itself and the shape of the pulse and the rate and how it's expanding. It's more sensitive,
Okay.
more data,
So,
Okay.
and
so,
there's
so
more
you
data
could,
coming from the pseudomotor testing, from the fat distribution. It's just more data, more logarithm, and that's the reason of the cost of the 45,000. But if you have a patient for $200 and you do all your patients, of course, because everybody needs to be screened, including myself, and I know my status here, and then after 3 months of treatment, whatever I'm doing, and then I measure it, and if I able to improve 50%, and I show the patients, hey, we did all this treatment, you're at 50%, but still we need to work on it so we can get you into the green zone. It's really it's incentive for the patients to know how much work has been done and appreciate what you do, and then making sure you end up optimizing the endothelial function autonomic nervous system completely. And also the beauty is the fat thing. The fat thing, the other system doesn't have it. This one has even the fat distribution, means that when Dr. Goldman tested, he doesn't have any fat. He's in the green zone. He's all muscles and bones, right?
Dr. Halasa,
Yes.
can I
Right.
share a picture with you that I think would help what you're talking about right now?
Go ahead, please.
Okay, this could help.
I think it's important to tell you that even though the machine is $45,000, it can be paid in 3 or 4 months, and also we have a plan for with non-APR for 2 years, so it's quite easier to acquire.
So and this the blood coagulation thing was the PDG VLF. You know, you see the marker for inflammation. These are all the way that photoplasmography, the waveforms are analyzed. So the questions that the two doctors were asking before about how can you make this kind of a discrete valuation, the light, the way it's interpreted, by the system, you've got very accurate measurements here, and there's a lot of science papers that show how well this correlates to much more in-depth lab tests. So let's see this. This also is referring to the tests that you can look at the correlations here, and you can look a lot of this stuff up, but it's an accurate test for the initial assessment. It's not supposed to replace the best of lab tests. It's just a very rapid way for you to know about how bad a person's endothelial is or how good it is.
Did you show it at the beginning? Maybe I missed it. Did you show?
This was that separate science booklet that wasn't part of my main presentation, and I had to get my hands on it in order for me to pull it up. So I apologize that. Your questions were really good. It's just that people hadn't asked me that before, so I didn't have this handy.
Okay, well, thank you for the explanation. I mean, it is very exciting, but I'd like to understand exactly what I'm looking at.
What will happen
Please
is now,
download this. I think this is a long document.
Dr. Selvey, let me make it clear. Dr. Joseph is going to have the system in his office. They're going there, so you live next to them.
Oh,
Right?
yeah,
You
okay.
go there and check it when Dr. Joseph has it, and those people are there, and you can be the patient there, and they can test you.
That's
And see
perfect.
the
That's
whole-
Wednesday.
Yeah, right. Because they all, Dr. Selvia lived next to Dr. Joseph. They're all the same team.
They're on this way, right?
Yeah, they have every day a brunch together. Dr. Joseph and Selvin and Shell, they're all the same gang, and they meet
We
up.
had-
That sounds like
Very good.
fun.
Wait, what was the last slide you showed? Insulin resistance? Because I think insulin is the biggest culprit of all.
Oh, yeah. Let me pull that back up. Yeah, and our insulin, the insulin resistance test is extremely good. And I could point you to one of the research papers where they go through, the accuracy of this thing. But I think that's one of the ones that
That's
got
fun.
patented because it's
It was the one
particularly
before.
effective.
It was the one before a green test. But that one.
This one?
That one I liked. Yeah, insulin. Wow, insulin's a killer. It
Yeah,
really
and
is.
incidentally, one of the groups that we're talking to is a military group. There's a human performance initiative with the U.S. Army, and what's really sad is that they're having this terrible problem with the recruits, where even though we're talking about 20, 23-year-olds, over half are really obese to the point that they're having terrible problems with high blood pressure, and they can't respond well to training. In fact, what they're getting is a lot of musculoskeletal injuries. And if they don't fix the problems of the high blood pressure and the insulin resistance that's plaguing, the obese recruits, they can't get anywhere in basic training. They actually have to fix the health of these kids that have been doing nothing but playing video games for 15 years instead of going out and working out like we did when we were kids.
Now, is that out of Paris Island or is that out of California, or do you know?
So well, I do know this is a major that's in South Carolina, and he's heavily into the Human Performance Initiative of the Army. He's a pretty famous guy in his own right. He's got like world powerlifting records, but he was also an Army Ranger, I guess.
What's his name, if you don't mind me asking?
Major Donnie Bigham.
Donnie Bigham.
Donnie Bigham.
Okay, thank you.
Anyway, he's somebody that we're talking about. It's a major change, and what our system would do is with the AI, I can take 1,000 or 10,000 people that we scan, group them into 30s, and that way at a platoon level, 25, 30, 40 people that have almost the same biomarker imbalances, then we pick supplements that are ideal for each group, and they're able to change, what they're getting at the mess, and give them supplement pills, according to Donnie, that would, be substitute for this kind of an approach. Obviously we're going to pick the ones that have pre-diabetic problems, or they're never going to get better. We got to fix that right away. This is going to catch it immediately, and it's going to catch problems with oxidative damage and all the different aspects of atherosclerosis. It's going to see that, and they're going to put people into a program that could fix them.
Amen. Wow.
We had a doctor at the show in West Palm Beach. He's cardiovascular surgeon. And when I did the test on him, he was very impressed that we could detect that he was insulin resistant. And he said, Mari, how in the world this machine is doing that? And I haven't given you any information, and you haven't taken any blood from me. Right. So it's very accurate. It's one of the strongest biomarkers that our machine has. Is the insulin resistance.
How does it tell that? Yeah, I measure insulin level, fasting insulin on every patient. I think that's a very important measurement. Only costs $10, but how is this telling what the insulin level is?
So basically, if you do have endothelial dysfunction, you have oxidative stress. That means those oxidative stress it's oxidizing your insulin receptors. So they made a study, and they find out at this level of endothelial dysfunction, rigidity of the blood vessels, you have insulin resistance.
Okay. But
They
it
did
also
it based on the rigidity of the blood vessel, correlating it with patients with insulin resistance.
Oh, here we go.
Okay.
The PTG total power marker of insulin resistance. So it's seeing that from just waveforms from seeing through the skin, and it's got an extremely high degree of accuracy when you compare it to all the best blood tests for that.
So let's say you got 100 patients, and their endothelial function test is this score, bad at this score, and those 100 patients, you will find 99% have insulin resistance. You got
artificial intelligence, I think, is the easiest way to question or to answer the question, Dr. Lewis, is artificial intelligence is now picking through all this stuff, and it's starting to figure out these levels of insulin resistance. And it's hard for us to understand. I don't understand it either, but artificial intelligence that you guys have implemented is now starting to pick this system apart. And I think it's really wild what's going on, and we just got to get used to it and figure it out.
Working with scientists and doctors like you guys, we can take a wish list of what functional medicine needs. It's an incredible, powerful system that we've, the base part of this that we have already. And most of the ideas that I think could come up here would not be difficult at all to implement. And with all of these 30 plus biomarkers, to track, all the changes with treatment protocols, it's a tool that can only get stronger, with your involvement.
Yeah, I think, let's say, for example, this is how this is. 100 patients, endothelial dysfunction test is, let's say it's moderate. And then those 100 patients, they measure the hemoglobin A1C, and they find it's around 7. So on this endothelial function test, this score is correlated to 7 hemoglobin A1C. If it's severe, it's correlated to 8 or 9. And that's how they come up with this. So
Okay.
it's not something that they are measuring directly the hemoglobin A1C. This is they correlate the endothelial dysfunction score with those patients, the data they collect with the hemoglobin A1C. Does that make sense?
Okay. Yes, yeah, it does. You saw a funny comment on the AI. The AI machine is asking us to answer questions that I'm not a robot when I'm answering a question. I said, it's so funny. You know, are you a robot? I'm not.
It's same like your son. You remember your son? He's coming up with the treatment protocols for cancer based on
Yes,
the AI. He's collecting all the information. Okay, this is genetics of the sensitivity to those cancer, and this is the drug that they use. And they, with the AI, they can collect all the data and they can correlate. That exactly the same concept here.
right. Well, they have 4,000. Like nobody has studies of more than maybe up 20, 30 different cancers. 4,000 is a lot of information. Yeah. But anyway, and I learned a lot and I enjoyed it. And you know, as a cardiologist, I'm always concerned about the endothelium.
And if you're going to be around on Wednesday, close to Dr. Joseph, we will test you and explain a little bit more about it.
Oh, you're going to be at post haste? Oh, you'll be there?
Yes, we will go together and with our technician. And
Okay.
yeah.
I'd like to see how it works. I'll call Dr. Joseph, and you know, well, I'll get up there on Wednesday sometime.
Wednesday at 10:30 we'll be there.
Okay, I look forward to meeting you and learning about this.
Same here.
That would be great.
Okay,
That would be great.
thank you. Okay, thank you.
Okay.
Are we all good? Can we say good night, everybody?